now our 12th Pinnacle lecture series. I'm very excited to say that 12. That's like, this is a habit now. We've been doing this. I'm Susan Gennaro. I'm the Dean of the William F. Pinnacle School of Nursing. And we've come together all these 12 times as a nursing community to focus and hear about research and leadership and where the world of nursing is going. And we are very thrilled to have so many of you back again. We really appreciate having our preceptors, having alumni, having students and faculty. And I'd like you to know we have a few special guests tonight. Carol Lupi, who we have been working with for a very long time, it feels like, but she's very young, so I guess it wasn't so long. Judy Beal, who is the Dean of the School of Nursing at Simmons. Dr. Rice Simpson is going to be telling you about some of her research that she's doing with A1, and we have the past president of A1, Mimi Parmelo, who is also a graduate of BC. So we're very blessed in the richness of our community here in Boston and how well everybody works with each other. So thank you for all that you each individually do for BC and for our students. So at this point, I have to tell you a few things that are important for you in terms of continuing education. We're offering 1.5 contact hours provided by the Boston College Pinnacle School of Nursing Continuing Education Program. And you will get all the information about that if you've registered. If you haven't registered, on your way out, you want to register at the desk in the foyer, because then they'll make sure that they send you the online evaluation and a link with your email address so that you'll get back information about your 1.5 contact hours. It was just my birthday, and you know how that's when they look at how many contact hours you have. So I was going through all mine. This is very top of my mind, wanting to make sure you all get this because it's important. So now to our guest. Tonight I really have the true pleasure of introducing you to Dr. Kathleen Rice Simpson, who is the editor of MCN, the American Journal of Maternal Child Nursing. She's also the chair of the National March of Dimes Nurse Advisory Council, and she leads an investigative team for the Association of Women's Health Obstetrics and Neonatal Nurses, A1, which you're going to hear about some of the work that they do. Dr. Simpson is a prolific, and I don't say this lightly, author, consultant, and perinatal nurse clinician, who is one of those nurse scientists who, and I have always found this fascinating as I've watched her career, has done her research from a clinical base rather than an academic base. Got her doctorate, she'll be telling you a little bit about this. She's a graduate of Jesuit institutions, got her doctorate from St. Louis University, but has really stayed very close as a perinatal clinical nurse specialist to the bedside and thinking about what kinds of information we need to provide better care. So she's a leader in the quality and safety of nursing around childbearing women, which, being an obstetrical nurse as I am, is very near and dear to my heart. I've had the pleasure of working with Dr. Simpson over the years on a number of things, but most recently as a member, she's the chair of the March of Dimes National Nurse Advisory Council, where she does absolutely outstanding work to make mothers and babies in this country have much better experiences. So it's truly a pleasure for me to welcome Dr. Simpson and to introduce her to you as she tells us about her work. Thank you.
Well, only the sturdy arrived here in Bed. Snow, right? Wow. I wasn't expecting that, but it's beautiful. So I'm going to talk about some of the research I've been doing over the last few years about maternity care, looking at quality and safety. And you can see on the right, those are all my colleagues there. And on the left are all my grandchildren. So they make wonderful subjects. So lately, you know, when you make a presentation, especially at a national meeting, you have to have permission to use photographs. So to avoid that, I take them all myself. That way, I don't have to worry about that, because it is quite tricky to have, you know, go get permission, etc. So all these pictures that I took myself, or there's a couple of me in there, but I didn't take it, but basically, I've used the births of my multiple grandchildren as subjects. And then as said, I'm the editor of MCN, so I put my latest grandchild on the cover. Yeah, you can do all sorts of stuff when you have a journal that has the ability to use pictures. Yeah. And I have another one, you're like 4 months in advance, so like the one that's going to be covering Halloween is about to come out. So I have one of my grandchildren who dressed up like a cowgirl. She's going on the cover of the one that's going to cover Halloween. So that's kind of fun. So these are some of the things that I've been studying over the years, and I'm going to talk about the things that are highlighted here. But, overall, it's been the theme of patient safety and looking at how to provide the best care for mothers and babies during labor and birth. That's the key thing. So I've studied a lot of things, and but they're all within a very small area of practice, which is labor and birth. Right now, I'm looking at nurse staffing, which is a very important thing and hasn't really been studied in our setting. So I'll talk about the A1 study, about nurse staffing. I'm also looking at alerts and alarms, which again hasn't been studied in perinatal nursing, and then discuss some of the statewide perinatal collaboratives that I've been involved with and what's going on around the country. But these are other things that I have studied over the years, some of them as randomized trials, and then I've also been involved as a co-investigator or site coordinator on a number of other randomized trials as well. So there was an opportunity to learn quite a bit about the research process in providing, participation, I guess, and getting everyone else at the hospital. So as Dr. Gennaro mentioned, so I'm not in the academic setting. I know not much of that world, I'll have to say. And I hear a lot from my friends of certain pressures and, things that you need to do, and I think, oh my gosh, well, I don't have to do that. I don't have to worry about that. And so it's been kind of a freeing thing. On the other hand, they don't have that infrastructure that a lot of the universities have where, I've worked with some teams where they have this whole office of all these people that do things for you. So I haven't had that, so I've had to recruit. So I've had to get funding to have people help me. And that hasn't really actually been that hard. But, it's just a different perspective. So in the clinical area, you have a lot of opportunities. I work at a Mercy Hospital in St. Louis, which is the largest Mercy hospital in the United States. And we have almost 9,000 births a year. We had 8,700 babies last year. And so that gives an opportunity there's so many patients, potential people who you can enroll in your studies. And they're all very gracious, and we really have very few people that say no. They're all, oh yeah, sure, but so it's been really wonderful. And with funding, then I can engage some of the labor and delivery nurses that I work with to be on the research team for a while, and then the hospital's been very nice in letting them go back to their normal L&D job. So it's, it can be fun to join a study for a couple of years, and then go back to your regular staff nurse position, and it's been really fun. So I've had a really good run being able to conduct research. And one of the things that made that possible is having great support and having a boss with the doctor. Having somebody that understood that the role of clinical nurse specialist involves practice, research, and education. And then being able to say, hey, by the way, I want to make sure that I get to do all 3 roles. So I want to carve out that time. And so at the time that I took the job, there weren't that many people that had the job. They were hiring a lot of clinical nurse specialists in the hospital. And really, they weren't unsure about what that role was. So we all got together and decided that that's, we were going to stay true to what we all had been taught. And so that was kind of, I guess, a blessing in that if I had been filling in for somebody else who really was in the CNS role that did just all education, for example, then maybe it wouldn't have been so easy. So I was very lucky. It's all being in the right place and right time, and I was a very lucky person. So anyway, so I'm in this, huge maternity service, lots of things going on, and lots of support for doing all sorts of research. So I will talk about these studies that I have going on right now. So this is the A1 study about staffing, and that's our team. And then we have the people at the national office who are doing the, helping us, and who are assigned or have assigned themselves to the A1 staffing study. So since there's really no studies about staffing in the perinatal setting, we had to start from the beginning. We had to go to the people who staffing during labor and birth makes a difference to, which is the patients, the physicians that we work with, and the labor nurses, to find out where we should start and what we should do. So we are studying the implications of being busy. So this is sort of an example. So you see someone's being rushed to have a cesarean birth, and they get in there, everything's, it's rushing around, and then you have the baby's pink, things are looking good. But what about all those other people that you left behind? So if you have a crash, there's other patients that you might have. So here's other people that are in labor. What about them, while your patient's in the recovery room? So some nurses in the United States have another patient or two while they're running down the hall with someone who's having an emergent cesarean birth. And then when they're taking care of somebody in the recovery room, which is supposed to be 2 hours of very intense Q15-minute assessments, they might get, since their patient's about to go to the mother-baby unit, they might get the next patient that walks in. They might get another assignment instead of being allowed to finish that recovery. And during those 2 hours, there's a great risk of a postpartum hemorrhage if you're not paying attention. Lots of things can go wrong. So you really do need to have one-on-one care during that time. And that's long been recommended, but people kind of, they get loosey-goosey about what should be done and say, hey, you take the next patient. Well, it takes a good 30 to 45 minutes to work up someone new who comes in, a new labor patient, so you don't have time to be running back and checking on this patient. And you don't have time maybe to be doing the frequent assessments and helping the mom breastfeed and making sure that the baby is safe. There's been a lot of push for keeping mothers and babies together, but not a lot of thought about what that means in terms of newborn safety. So, you can tell the mom, hey, you got to keep your baby for the first 2 hours, but if you're not in there paying attention, that baby can suffocate at the breast, the baby can fall out of bed. All these things are happening now around the country, unintended consequences of baby-friendly initiatives that have not been really evaluated for what that means for staffing. So if you leave a mother alone with her baby after she's had 20 hours of labor, and now she had an unplanned cesarean and she's a little drugged up, how's that going to work out for her? If you can't come back and see how she's doing for a couple hours. So these are really important things, and we're trying to look at what are the implications of being too busy, and how does that potentially impact patient safety. So that's basically what we're studying. So there's two kinds of being too busy. And if you are working in a hospital, you've probably experienced both of these kinds. Hopefully, you're only experiencing the acute kind. Things happen. So in maternity care, you could be doing just fine, and all of a sudden 2 or 3 women show up and they need to be assessed, and maybe one of them's a, imminent birth. Everybody can handle that. And you might not have the exact staffing, the ideal staffing that's recommended, but you have to step up and make sure you take care of it at that time. The chronic is the worst. That's the hardest, because then that means every single day you don't have enough nurses. You don't have enough to do what is needed for patients. So when we decided to go and ask nurses, physicians, and patients about this, they told us about these 2 different things. So we did open-ended questions and really did not try to lead people in the direction that we were, that we were hoping to. We just wanted to ask, tell us what happens when you're busy. How do you decide what to do? What needs to be done? What can wait? And, well, what you're just not going to do at all. What can't you do? So we've been talking about that. So when you're busy, important things can be missed. So we first went back and we decided what was going to be the theme of this research. We went back to a survey of about 900 A1 members when we were doing the staffing guidelines. We asked them, what should we consider when we're writing staffing guidelines? And we didn't have, which is sort of a mistake, but a blessing. So we didn't put a limit on the words. So people just went on and on. It was awesome. All the stuff they said. And so we've been able to then go back to that data, and not only did we get their suggestions about what to include in the staffing guidelines, they told us what happens when there aren't enough nurses and how things can be missed. So we started thinking about that. We went to the literature and we saw that other people are studying miscare. And there's a long definition about that. It's not just miscare, it's unfinished and delayed care. But we thought, well, maybe we should look at that. So that's kind of where we got the idea, looking at the first series of data from labor nurses and A1 members really, and decided that we would go from there. So we got that idea. And since then, ARC's been interested in this and has some, there's a primer out there talking about miscare. There's been actually, over the last 10 years or so, quite a bit of interest in that. And there's 2 teams looking at this for the most part. So we decided to use the definition and methodology from the University of Michigan Ann Arbor and go with that, although again, there's other people talking about this concept. And so first, I just kind of want to go over what we found in the literature, and normally each one of these things would be cited and all that. There's plenty of citations for all this, but over the last 10 years or so, we have found that better staffing is better outcomes. Now, there's some flaws to this data. There's, you could pick them all apart, but overall, you're seeing a consistency that you have better outcomes and better processes when you have better staffing. And it makes sense, but you have to take the time to study this and do it rigorously. So this is what's in the literature right now. So what we decided is, well, okay, we don't have any guidance about perinatal nursing. What are we going to do about that? So we have to start from the beginning. So that's why we again decided to interview all these folks, or hold focus groups, and look to the literature. And that's how we came up with looking at miscare. So Dr. Kalish from Ann Arbor is the one who's been writing about this, and we went to the ANA staffing conference a couple of years ago, and I had never met her, of course. I just saw her walking by, so I stalked her for a while and said, hey, oh my God, you must be, and she said, yes, I am, So I said, how about you take a picture with us, because we're using your work to, we've designed this study based on your work. She was very, very nice. And in fact, she came over and said, could I have lunch with you guys? Because I'd like to hear more about your work and, what are you doing? And, we were actually doing work in DC that day, so we had some of the stuff with us about our study. And we showed it to her, and she said, let me think about this. And then she spent the afternoon when she was supposed to be listening to people talking, critiquing the tool that we had adapted. I mean, what a nice person. It was really sweet. So she has this tool that can measure miscare. However, it really doesn't have much to do with what goes on during labor and birth. So we had to then adapt what she had done to what goes on during labor and birth. So again, the reason why we chose this is because we already knew that there were some definite relationships. So the miscare is like a hot topic right now. People are writing about this. Someone just wrote something in Nursing Outlook this month about that, and there was another article in the International Journal of Nursing Studies, a review, a meta-analysis. There's been a lot written about miscare. And so, just like staffing in general, there's building a body of literature about what relationships miscare, which again means not completely missed, but missed, delayed, or unfinished, etc. So we thought we were on the right track. And this is from that review article I mentioned. So when we decided to ask nurses and patients and physicians about this, they mentioned almost exactly what is in the literature. So we didn't tell them about this concept. We just said, tell us about what happens when you're busy. And how do you make a decision about what absolutely needs to be done and what can wait. And after we got a lot of discussion about that, then we said, well, what happens when you miss things? And what happens when you can't do this right away? And they were so eloquent about all the things that can happen. What we were hoping, though, is that we would get more out of the discussions about concrete things that we can measure. But everyone, including the patients, have a general assumption that technical aspects of care will be done, and they will be done in a quality manner, and then we want to talk about that. Because they're assuming that's happening. They assume that. What they wanted to talk about, all three groups, was about supportive care and being with the woman and how important it is to help the patient and make a good experience. Patient experience, well, I know it's important for nurse administrators, but it was important for all these groups where they said, oh, the patient experience is actually an outcome that you should be measuring. And, you know, we hadn't thought about that. We thought we were going to be measuring technical aspects of care that could be missed, but in fact, that's not what anybody wanted to talk about. But you can see, though, that some of these other things are a lot harder to measure. So after we talked to all these folks, about 95 of them, various focus groups around the country, we came up with, these are some of the things. So if you're not a labor and birth nurse, you might not be familiar with this, so I'm just going to briefly say, so these are some of the things that nurses, physicians, and patients thought were important things, essential aspects of care. So when we ended up adapting the tool, we didn't have a lot left from the original tool that was for medical surgical nurses, but they were similar. So these are things that you would do, and they're important things. Each one has a rationale, important things to keep the mother and the baby safe during labor and birth. And some of these you might think are very precise. That's just because they're the standard of care. So we wanted to be precise about how many minutes, or what you were supposed to do, just because those are standards by which people are judged. And there was so much documentation, so much talk about documentation. Nurses are quite bitter about the electronic record, and me too, actually, because as a researcher, when we got our electronic record in 2009, there were all these promises, and they gathered all the researchers in the hospital together and said, we need your support. So, and here's what we can do for you. But none of those things have ever been realized. We've had a heck of a time. So I think that the electronic record will be a wonderful tool for researchers, but just not yet. It's hard. You have to do a lot of manual review in those electronic records. But people talked about the inability to document in a real-time fashion. And that was one of the things that people said, this electronic record's going to be great. You'll be able to do things right away. But it's cumbersome. You got to log in and multiple screens, and then you're trying to watch the fetus. You might not have, very difficult. So people talked about that. A thorough handoff. This is very important. And when you're caring for someone during labor and birth, it can happen in a second where you have to say, watch my patient. I got to go with this other gal who's, pre-sipping, or she needs a crash C-section. And that's all you have to say is watch my patient. You don't really get to say anything else. So thorough handoff is very, very important, and yet often when the situation is very dynamic, you don't get to do that. And these are other things like those of you that work in a community hospital without physicians in-house or a midwife in-house, you don't want to have the baby coming out unless they're there, but it happens. But that was something they really wanted to say, that's an essential aspect of care, to be able to take the time to make sure they get there. And then breastfeeding within 1 hour of birth for women who are breastfeeding, that's one of the Joint Commission measures, looking at promoting exclusive breastfeeding, this recovery care that we talked about before. I was very surprised in going around the country that this is an area that I thought we had pretty much had this covered, that people really do have to take another assignment during the recovery period. I was surprised by that. Because again, you need to be in there making sure that gal's not bleeding and that the baby's okay, and yet this is really a problem. Now, at our hospital, they did a quality improvement project about recovery care, and they were going on and on, and I said, what's the problem? And they said, we're not meeting this standard. So I thought, well, how could that be? I mean, they got to do all this stuff. What their quality improvement project was, how to get it down from 3 hours to 2 hours. I thought they were just trying to say, they didn't have it long enough, but they were saying that because of all the things they have to do, it's going longer and longer, and then backs up everything else. So this is a really critical time for newborn safety and for mother safety. And this is what they told us were the reasons for why they might miss care. And these are same things that might happen on a medical surgical unit. So, similar things that you would be familiar with. And they were they talked a lot about how the regret of it. So that not only were there, factors that didn't allow them to do what they wanted to do, but how bad they felt about it. And I can see that. You know how sometimes you leave the hospital and you feel like you really did something. You made a difference, it was awesome. And then sometimes you go home and you think, wow, I tried, but I wasn't very good today because I didn't get to do this or I didn't get to do that. They talked a lot about that regret. Now, during labor and birth, unexpected increase in census and acuity is a thing that happens all the time. You can be very well staffed and have lots of plants, still happens. So that's different than a med surgeon, although, I think they, people can code on a med surgeon, I guess, but, all of a sudden somebody having a baby and, like we're in a high volume place, we could have 7 births going on at the same time, just, lots of things going on. All right, so this is a review. So this is what we asked them, all right, what do you think that you do that contributes to outcomes? So instead of saying, I monitor the patient, I understand the strip, I call the doctor and all that, they said, oh, everybody does that. This is what makes quality care. This is what makes a difference. Being able to explain what's going to happen when the woman comes in, build a relationship, being there, it's so important. Advocacy and supporting them. So this is what the nurses felt was their most important thing. And this is what they can't do first when they're too busy. So everybody's going to do the technical aspect, but this is all going to be first skipped. Then to the patients. That was so fun interviewing these patients. So we had 2 focus groups, in total about 25 patients. It was very interesting because we did it at the breastfeeding support group. So we had all babies, less than 6 months old. So we had lots of crying on our tapes, and it was just so interesting, all the things they were saying. And they were adamant that nurses help avoid a cesarean and how they had helped them avoid a cesarean, which was very, very, very interesting. So this is all kind of similar stuff, supporting me and helping me with breastfeeding and skin to skin. That's what that means, skin to skin. And then physicians also said similar things. But they had a perspective that was different in that the way they talked about the nurses was not as a nurse, as an independent practitioner. They talked about the nurses as extensions of them, which was an odd thing, So it was really like, well, they're doing something because I can't be there. They're doing this, but it's really me, and I'm telling them to do these things. Their perspective was that the nurses and all this care was an extension of them, and I was surprised by that. But anyway, and then they were particularly irritated that nurses make them follow policies. And as a clinical nurse specialist, that's been one of the hardest things about the job. I mean, I've had a lot of success as a clinical specialist and lots of fun. But that was probably the hardest thing, was being that person who, like it's Kathleen's 39-week policy. Instead of, hey, wait, I didn't, actually, just stuff like that, or instead of looking at, hey, wow, your professional organization supports this. So that was very interesting. They went on and on about that. But there were quite a few similarities, as you can see, with the nurses, new mothers, and physicians. Except the patients and the physicians were much more adamant that the nurse helps them prevent a cesarean birth, or helps avoid a cesarean birth. So then we thought, well, we didn't really ask the nurses about that, and specifically we were asking them about what gets missed and what are important things. So then we had to reconvene based on our data. We had to go back and have a couple more focus groups to ask the nurses about it. So this is tricky business, trying to study the role of the nurse in avoiding a cesarean, and it has been tried a number of times. So it seems simple. Hey, you can measure this, but it's really actually quite complex. So there was the first study about this in '93 that looked at retrospective review of records, and they were able to link a nurse and make a cesarean birth rate for nurses. Now that study's got some methodology issues, but it was the first one that came out and said what we all know, is that actually there is a big deal, and that you can think of on your staff, among your colleagues, you can think of one person where you say, oh no, I have to hand off to her, my patient's gonna have a cesarean. Or oh, thank God, I'm handing off to her, I know my patient will be okay. All right, you know that, but is it hard to measure? Absolutely. So anyway, these are some of the studies that have been done. The one I was involved with is the study, the supportive care and labor trial. It was a multi-center international, but just Canada, United States, randomized trial. That sounds good though. And so we enrolled at our hospital about 1,300 of those patients. And well, there was no difference in outcomes between one-to-one care during labor or routine care. And that was a big disappointment, a learning though. We learned a lot from that study and the difficulties in really measuring this concept. So then there's been another study looking at this as well, but not a randomized trial. This does make sense. So in high volume centers like the one I work at, you do actually pass off care between nurses quite a bit. Whereas in the low volume centers, you might have that same patient in labor, but when you have a really busy place, there are multiple nurses taking care of the same patient. They don't really mean to, but that's just the way it goes. So they were able to link continuity of care versus there. But anyway, so we are going to look at this. We're trying various things. We have a feasibility study going on right now looking at the medical record and what can be gleaned and how that can be linked to a specific nurse. And we have data about our physicians as well. So we're looking at this. And then also in the, we will be collecting data about the Joint Commission's indicator about low-risk women who have a cesarean birth. So we did go back and ask, we had 2 more focus groups, and we said, hey, the patients, the doctors are telling us you make a difference in cesarean birth. What do you think? And they were like, well, of course we did. And I said, all right, fine. Then what do you do? What do you do? They just went on and on, list after list of all the stuff that they do. So I think we're on the right track. We just got to now figure out how to measure this in a rigorous way, and that is extremely challenging. So basically, in summary, we have interviewed lots of people. We got our survey ready to go. So we validated our survey. We've tested the survey. We've had people try it. We've got our administrative data ready to collect. And in the next week, we will be starting now this survey, which is an adaptation of the miscarriage tool in New Jersey, Michigan, and Washington. And then we will be looking at various aspects of care, including we have some self-reported staffing, and then again, administrative data, and we're also looking at the number of FTEs per birth, excluding NICU nurses. So, this hasn't been studied. This is, beginning. I'd like to say we have 10 years of data and we're really, really far along, but we're not. So nobody's studying this. So hopefully it'll turn out okay. All right, the next thing that we're studying, and I've studied a lot about fetal monitoring over the years, is about these alerts and alarms that go off when you have a patient on a fetal monitor. So here you can see, and this is from our hospital, so every one of them's going on. Well, I think maybe 1 or 2 doesn't have a yellow line. They're all going on. So here's sort of the issue. So you have all these things that are sending you alerts. And we have a brand new hospital, so a new tower, and so we have the latest. So things go to the cell phones of the nurses, they, depending on what team you're on, I mean, it's very sophisticated. Nevertheless, so they just get all these things. And then, of course, that's a baby alarm that goes off if you don't put the bracelets on right. The IV pumps, those are the worst, because we have these huge rooms now. You can have as many people as you want. This is, I've never seen rooms this large. But our hospital has a lot of money. We spent $30 million building this 75,000 square foot labor and birth clinic. And so these rooms are huge. So if you have an IV pump in there that only makes noise at the bedside, that's a real problem, because then you got to turn it up to the highest volume so that the nurse outside can hear it. That's really irritating when you're trying to rest, during labor or whatever you're trying to do. And plus, if nobody comes when it's going off, you got to wonder, is someone caring for me? Is someone watching me? Oh my gosh. And, we've been working on this for a year, and then my husband went to the hospital and was in there for a short time, like 24 hours. But all this same stuff is going on. The IV pump thing kept going off, and I thought, where are the nurses? How, you can't, did nobody hear this thing? He finally figured out how to turn it off, but still, I mean, all these things are going on. And I was like, wow, this is just what I'm studying, and not, the patient perspective too. I mean, terrible. So anyway, all these things are going off. The nurse has got to worry about all these things. And then there's we don't have a locked unit, but some people have a locked unit. So then you got to answer the door too. Somebody's at the door, then you got to look at the camera, see. Now, how are you going to tell if it's a bad person or not? You usually like, yeah, okay. It's really ridiculous, but we don't have anything. So these are all the things that could be going on. And we also have nurse locators as well. So like down here, we can tell where all the nurses are, where all the babies are. And then if they're not in the right place, then again, that all starts going up. Then we have our fetal monitors, and then the physiologic monitors, and the IV pumps. And so imagine as a staff nurse, all these things that are bombarding you. And you're trying to filter through, what's important? What should I do? Which one of these things are generating something that's actionable? Or do I just need to know? So what we did on this study is first we thought, okay, this can't just be our problem. So we convened groups of adult ICU nurses and NICU nurses, and then the rest of them have all been labor nurses, asking them these questions. And what we found is there's big differences between how various specialties perceive these alarms. So the one thing that we found that I think is really a problem is that, so there's 7 vendors of fetal monitoring surveillance systems in the United States. Every single one of them has different alarm parameters. They come from the factory, they're default settings, no one changes them, because there's no evidence for what they should be. The main vendor, there's 2 main vendors, so one of them believes that they don't want any liability. So their alarm settings are so generous that you probably could be dead and it wouldn't go off. You'd have to be good and dead before it went off. I'm serious. Theirs are very, very, there's many minutes before anything's going to go off. And then the other one has very tight settings. So you have to think, well, what are they telling us about? Is it that you need to run to the bedside right away? Or, you need to, as a staff nurse, you need to know this is important information, but which is important, which of these things are important? So we don't have anything about sensitivity and specificity of these things. So the goal of this study, I'll just say, is to create alarm parameters for fetal monitoring, fetal heart rate patterns that have good sensitivity and specificity. That's the goal of this study. But we had to start at the beginning because nobody studied this. So we had to ask physicians and nurses about this, what they thought. And, then you sit on the unit and you see all this stuff going on. Nobody's paying attention to it. So they, have them all turned off. So this is one, we also then went to the data and we looked at, so this is one example of what's going on. And in this situation, they have one of the vendors, so it matters what vendor, they have one of the vendors that has a tighter numbers. And so they still have quite a few alarms going on. And then this is our system. So this took me forever. I hadn't done this for a while. I had to recode all these alarms because they come in like, I didn't know, they're very difficult to understand. But once I got it together, I still had to recode them all before I could do any analysis at all. So, and this is like 100,000 plus alarms. I had to recode them manually. Oh my God. But, it was important. I wanted to know. So here, 100% of the time, they're going on. They're always going on. And it's just about high, low, and no signal. Those are the main 3 things. So, low signal could mean a number of things. It could be innocuous. Maybe the patient moved. Maybe she's got a little extra, adipose. It's hard to get it. Or maybe the baby, there's a great party and you need to run in there. How are you supposed to know? You don't. And so this is a real problem. So, again, what we're trying to do is figure out when they should alarm, when they should go off, and get some good sensitivity or specificity. So we don't have that. Professional organizations have been totally silent. No one has mentioned anything about this. In fact, I've talked to people and they're like, this is a really so what thing. That's kind of discouraging, but I don't think so. So, but they're like, who cares about this? Well, I think it actually is very important. because if you're gonna let somebody know something, it should be correct. And it should be, at least have a high likelihood of being correct. So there's really almost no data about this. And then when I was talking to the ICU nurses, apparently there's only 3 main vendors of those physiologic monitors. They're all different too, but that's their problem. I can't study that, but still, I mean, you know, I was surprised because I'm like, oh my God, this is terrible. And they said, we have the same problem. They were going, I was talking to the nurses about a research presentation. They're like, we have to go to a meeting to set the parameters for our physiologic monitors in the ICU. And I was like, oh my God, I'm onto something. I said, well, what are you using for the evidence? And they're like, oh no, we're just going to sit around and pick it up. Oh my God. So, I mean, that's concerning because lives are at stake. You have to know what's accurate, so this is important. And the vendors aren't going to collaborate unless somebody makes them do it. And even though the Joint Commission only accredits like 94% of hospitals in the United States, they are the most influential because when they say something, everybody jumps on it. So then you have to ask yourself, all right, what's the purpose of this? So, you know, vendor to vendor, different purposes, which is important to realize. Some people only notify you of what's a major emergency, and other people give you early warning signs. So there's a big difference between evolving tachycardia of the fetus versus an abrupt fetal bradycardia. So anyway, those are some things like that. So these are the gaps in evidence, and we're trying to address some of these. So what should be alerted? Some things don't need to be alerted. When, and then how, all these things are very important. And then some things, which I think if they don't require an acknowledgement, they probably don't need to be alerting. There's just so much noise going on, so much data, like you need to know what's important. So, and then there's all these different policies, hospital, should you go to the bedside, an acknowledgement, or do you have to log in to acknowledge it? All sorts of things go on. And then if you're going to customize it, where's the evidence? How should that be done? So the critical care nurses say, you know, they should be customizable. Everybody should be able to, based on the patient. And so I'm not quite sure if that is true for the fetal heart rate, but you know, it's something to look at. And then what's the expected time frame? So if you're notified of a bradycardia, you probably should get in the room right away. But a fetal tachycardia, well, okay. So, you know, these are all things that are important. And then what's the purpose? So this is what we're looking at. We're in the early stages of studying this. But I think that this is a major question, is that depending on what vendor, and some of these are awful, I must say, these vendors, but I'm not naming their names or anything, but anyway, the safety of the mother and baby could be dependent on what vendor has been chosen by the hospital. You know, did they choose the one that's never going to go off, or did they choose the one that goes off all the time and drives you crazy? I mean, so this is really important, and I think that we need standardization of these vendors for fetal heart rate patterns, and that we can figure out the sensitivity and specificity so that there's some standardization, and I think mothers and babies would be safer. So that is what we're doing. These are some of the things that nurses told us. And so if they don't think they're useful, they ignore them, then, you know, what's the point? Census, so you get as many people as you can. So this has been the most successful across the country. This is the one that we put together first, and this is not one that I put together, but we put together similar things like this for the states, and they really felt that the time wasn't right. So now the time, I guess, is right for this. There's been a body of evidence that's been building over the last 10 years about labor management and how appropriate labor management can be helpful in helping that woman avoid a cesarean birth, an unnecessary intervention. And some people, you know, have various priorities, and for them a cesarean birth isn't a bad thing. It's not the woman. However, others, you know, really think, hey, you know, that's a major surgery. And not counting the fact that it's very costly, and you're going to have twice as long length of stay, and almost 3 times the cost of a vaginal birth. So some of these labor management techniques, I think, are finally going to catch on. In fact, there was a paper that got a lot of press last week. I don't know, it was in the Gray Journal, the American Journal of Obstetrics and Gynecology. And as a journal editor, I had to make I don't know anything about this, but I had to make a Twitter, I had to put together a Twitter account. But that's actually handy, because if you sign up for all the news feeds, then you can read all that stuff without paying a subscription. So I've actually found it helpful. But then I did subscribe to the ones I was supposed to, like all the other journals. So there was so much press last week about this randomized trial that was done actually in New York about labor management, and how if you just gave the woman one more hour to push, that you wouldn't have different outcomes, but you would have, I mean, you know, as far as you wouldn't harm anybody, but the cesarean rate of that group is like a 70% difference. It's huge, just one more hour. So for the woman in labor, one more hour isn't anything. But if you're hanging around and you need to go home, one more hour is a big deal. So it's very important to look at these labor management techniques, and there's more and more evidence, that's just one study, but more and more evidence that a little bit longer, and not looking at these arbitrary time frames, can help women avoid that primary cesarean birth. This is a public health problem. You know, 1 out of 3 women in America have their baby cut out of their belly. And I'm not, I mean, I am passionate about this. This is not right. This, you know, 1 out of 3 women could not be not built to give birth to a baby. So, you know, there are multiple factors causing this, and I am hoping that finally, you know, the maternity care team is ready to adopt this. So I'm very excited about this. And we've been working on this for 4 years, looking at this, and I think the time might be right. I hope the time is right, because this is a critical issue. So it's like major overuse. Have you seen the Choosing Wisely campaign about things you should not be, you know, doing just because you shouldn't be overusing things? Well, cesarean birth in the United States is major overuse. And then the morbidity and mortality of women who have that first cesarean birth with their subsequent pregnancies, there's a lot of things that can go wrong. They have a greater risk of hemorrhage and all sorts of other complications. So whatever we can do to prevent that primary cesarean birth, we would be doing a lot. So this is a big, big deal, and you're going to see a lot about this over the next couple of years. And your state will be enrolling in one of these collaboratives using this. So I'm very, very excited about this, and I think it's finally, maybe finally the time is right. And I think one of the factors that will make this right is that we're changing our model of obstetric care, so that physicians will not be having to worry about is the time work for them of birth, but in fact we'll have hospitalists, so that it won't matter because they're on a shift, they're working a shift, and so it won't matter when the baby is born. And I think that that is going to be the factor that changes everything. And then of course more midwifery attended births is the other thing. And this is just one of the other ones, hypertension bundle. There's been some pushback about this too. But you know, pushback is part of trying to make a difference. You get pushback and you move them. You try to get the right, you know, combination of people in the room to do something. So over the years, I just wanted to share, how do you get involved in these things? So volunteering. So the Jesuit way, go out and make a difference. That is the thing. I mean, you know, that's what I heard. And I was laughing about this talking to Dr. Gennaro. When I graduated, the dean from Loyola University, and I was like, okay, I'm going to go out and I'm going to do that stuff. And I did, you know, and I sent her the first article I got published. I sent it to her, and she got a big kick out of it. And she sent me a note back. She didn't know who the heck I was. You know, there was like hundreds of people in my class, but she sent me a nice note. And then I was in charge of the Nurses Week celebration at my hospital, and I thought, oh, I'm going to invite that gal down. So I did. She came down, and she gave a really great speech about nursing for Nurses Day. That was like, oh, that was so awesome. And she was just as awesome then as she was before. So it was pretty darn cool. She was a great person. And she was very inspirational. And that we learned all of that, again, at a Jesuit school, that you go forth, you make a difference, you volunteer. So these are some of the things that I have volunteered for. And if you step up and say, hey, I'm available, I can do this, then you put yourself in a place where you can make a difference. So the first thing I volunteered for was Alpha Sigma Nu. I was so thrilled. Sometimes I even wear that pin, you know. It's pretty cool. I was very thrilled to be in that Jesuit Honor Society. I have volunteered for the March of Dimes for about 25 years, and You know, the Joint Commission, I used to think they were the enemy, but then I realized that they are one of the most influential people. So I volunteered for them. And because of that, I have done all sorts of things in the background that have made a difference, and really important things where they, you know, they're desperate for clinical people to help them. So, you know, I said, yeah, I'll help you, I'll be on that committee, or I'll prepare this brief for you. I've written a number of their briefs that you wouldn't even know. But when people get to the end and it says the recommendations and then they all do it, wow, that's pretty cool, you know? So I've had a lot of good experience with volunteering with the Joint Commission. Then, of course, A1, my professional organization, specialty organization, and the American Academy of Nursing. Done some stuff with the National Quality Forum. These are all like really important things that have made a difference in care. And then even with ACOG and ACNM have done some things with them, prepared some documents for them. And, you know, that was really cool too. So if you put yourself out there and say, I'm available, hey, I could do that, or put me on that committee, I'll do that. You have an opportunity to make a difference. And other people who are too busy, you know, they miss that opportunity. So, you know, think about what you might be able to do. Start small. But all of these organizations in my specialty are the influence makers, the people who make policy. And if you put yourself out there and you do that, you can make a difference too. So it's been really fun. So even though I'm not in the academic setting, being in a big hospital with lots of resources has been, you know, set the stage for me to be able to do things. And I've had a great time. It's been wonderful, really. So, all right, oh, I guess I have, all right. Here's some more of my little children. Yes, focus on the patient. So if you say, what's best for mothers and babies, you know you're going to be doing the right thing. So I was telling some people here earlier, like I'm on this mission to change obstetric care to maternity care, because the name should reflect what's going on. So it's the woman who gives birth. It's maternity care. Obstetric care implies a medical model. It should be about the mother. So I always try to say maternity care as much as I can. And if I have to stop myself, you know, because you know you're so used to saying that. But really, what's best for the mother? What's best for the baby? If you think about that, then you're going to be able to do the right thing, and you can inspire others to go with you. And I took that picture. I took a lot of pictures that day. That was one of the few that actually. There were a lot of bad ones. Okay, so that we need questions. Any questions?
Kathleen, I really enjoyed your
Nice to see you.
presentation today. Yeah, this was really great.
Oh, thank you.
I
Well, now
have,
it's over, so I can.
well, you know, I think as a bedside nurse for over 25 years, actually, in the situation of caring for patients, and now as a nurse executive traveling all around, you get different perspectives on this very question that you're trying to deal with in terms of the staffing and the alarm. So I have one comment and one question.
All right.
Comment is easier first. I actually worked with a vendor where we did early warning signs in med-surg and critical care, and it was an international study that we did, so we could get a huge sample size to come up with critical parameters, and I could talk with you after
Okay, that
this
would be
about
great.
that, and would be happy to do that. That's the comment.
All right.
The question is, I think it's extremely valuable what you've done to get from the nurse's perspective what they feel is going on and what's impacting their ability to give the best care to mothers and babies. The part that I'm curious about is, what is the role of the nurse manager or the nurse leader or the nurse director? Because I can tell you, when I've been in that role and we got all hell breaking loose on the unit, we have several rules. Number one, you don't just shoot to somebody, hey, watch my patients. The person that's in charge of that unit is situationally aware and needs to be either the nurse manager or the director of the unit, so that all the information goes to that person, and if they're situationally aware, they will pick who needs to be watching who in an emergency. So I'd be curious if we could get some data from those people, number one, how active are they in managing the unit so the nurses can care for the mothers and the babies and the patients? And number two, what is the relationship between the nurse manager or director and the chief of OBGYN? I have turned PIT off. I have delayed people coming in where we have control over the inductions. But again, it's that collaboration that you did allude to and the teamwork. But who is providing that education to those nurse leaders who are responsible for the unit? We haven't heard from them.
Well, one thing is that you can't expect today that the nurse manager even, or the director, is going to be an OB nurse. There's going to be a labor and delivery nurse who could interpret a script. That's not reality around a lot of hospitals these days. So the way people move around and, they cut management positions or director positions, the director, especially in a smaller hospital of OB service, maternity service, might be a critical care nurse. And even in our large volume center, we said, hey, we're firing your boss, and the new person, she's great, but she's a critical care nurse. And she's done a fantastic job, but okay, so that takes that person right out of the mix. They're not going to be able to watch a monitor or do any of those things. So you can't really count on that bedside skill of the leadership group. You often have to count on the charge nurse. And sometimes, many more times than it should be, the charge nurse has a patient assignment. Well, those are all complex things that really have an impact on the dynamics of what's going on. And then working with your OBGYN chief or chair, whatever the title is, you have to be able to say, well, we're not, we won't be calling in anymore, inductions today. And, I mean, that's critical. And sometimes you have people that are raw pain say, I don't care, I want them to come in anyway. And so you just can't do that. And we do have that pretty much down to a science at our place, but it didn't come easy. It did not come easy. And we've tried all these different things about inductions. And the bottom line is we should just stop doing elective inductions, then we wouldn't have that problem. And so, I think we're going to get there on that too. We should stop reimbursing for elective inductions, in my opinion. I don't think that, if you wanted to have some other elective procedure, insurance wouldn't cover it. If you choose an elective induction and it's your first baby, you're buying 20 hours of intensive nursing care and a higher rate of, having a cesarean birth. Why should, again, that's another public health problem. Why should we as a group, as a community, insurance, why should we pay for that? The induction rate among Medicaid patients is quite low because they don't get the choice, so we shouldn't be paying for that, and I think that it should not be done. Those are we shoot ourselves in the foot by creating our own prices and acuity and census by doing artificial things. I could talk for 8 hours about these artificial things, and I know you want to hear, but I'm very passionate about stopping that.
Yeah, I think we have a systems issue. It's not just the nurse at the bedside. To your point is, do we appoint people that don't have the critical thinking and the clinical skills to be able to manage a unit actively to keep patients safe?
Well, sometimes, again, you don't have that luxury. You're in a smaller hospital. You have to have a director that's running several services. So, it's not going to be reality or realistic for many hospitals. It used to be, but it's just not like that anymore. From my understanding.
I can talk forever and I don't.
Yeah.
We'll talk later.
All right.
Thank you.
Anything else?
Hi, I'm Susan Grimes. I work at New Wellesley Hospital Delivery Room for the past 30 years.
Oh.
And one thing we just started that is just fantastic is called safety rounds. And safety rounds occurs on the day shift at 9:30 a.m. On the off shifts, they pick a time that works for them according to that particular day and workflow, where neonatology, key people come in.
Anesthesia providers,
and nurses give reports on their patients.
Yeah.
And so much learning has
is spreading around the country. That's it, important. You should write about that.
We really, I am, okay? The other thing is, we are, it's a struggle, the induction thing, because of, all the different stuff on the internet that patients read, and then all that undertow. But, we're pretty tight on that. And,
Tied on what, the 39 weeks, or tied on letting you?
preventing, elective inductions.
Because the standard says you should await spontaneous labor until
Right.
41 weeks. That's the standard. So if something happens in those 2 weeks, then
Right.
you violated the standard.
Right.
Those are clear,
Then we've got, and I'll pass it back now, but then we've got the other thing where people are having so many ultrasounds that tell them all these scary things.
Yeah,
that
that's a
resolve
major
at the
scam.
end.
Overuse.
And, so there's just, I think that's another whole key thing. When you
Maternity
do
care in the
tests-
United States needs a complete overhaul.
Yeah.
And look at the things that are good, the things that focus on the mother and the baby, and the rest of it, should not be done routinely.
Thank you
It
very
really
much.
does. Thank you. Okay, I think I'm out of time here, or I can't see that any other hands. Thank you.
I will turn it.